Thank you for joining us this afternoon on this Halloween Eve for this important presentation, which is a Maryland OSHA and federal OSHA update for medical practices. We thought we would have this today. We're trying to demystify OSHA. We're trying to make sure that it doesn't spook you and your colleagues, and that we provide some very practical information to help you and your practices comply with these regulations. We want to remind you today that this is being recorded. It will be available later to all of our practice administrator members, as well as uploaded to YouTube. And we will make sure that goes out in our e-news on Sunday. Also, I want to encourage you to continue to be muted during this entire presentation so that we don't hear the background noise that goes on in your medical practices. We also want to encourage you to use chat if you have questions, which we anticipate that Christina will be able to answer at the end of the presentation. So we anticipate the presentation will be roughly 1 hour. That does include time for questions and answers. So I'd like to get started. Again, we thank you for joining us. Christina Campbell is our presenter. She is with Maryland Occupational Safety and Health in the Maryland Department of Labor. Today, we have two of our partners that are sponsoring this particular presentation, Handcraft Linen and Medex Waste. And I know that I see Tony, who has joined us with Handcraft. Tony, would you please just give us a little brief rundown of what your organization does and how it can help our practices stay compliant? Thank you, Tony.
Thanks, Susan. Thanks for inviting us to this and allowing us to join in. So Handcraft Linen is a healthcare only linen service provider where we provide and launder all of the linen for patient care as well as staff safety, such as fluid-resistant gowns, lab coats, etc. We follow all of the OSHA regulations in our laundering and delivery process. We meet all of the healthcare standards such as JCO and
Take the month, November, December. There's no big for this, so that's
just about everything there is that we do. In fact, meet all of the requirements, etc. So that we're happy to help you through the process of staying compliant at all times. We're fortunate that we deal with a lot of the members of the society, and we've met so many of you over the past years, and we'd love to talk to you about it if you're interested in anything at all. So feel free. My contact information is on the County Medical Society's website. You can feel free and contact me directly. If there's any questions, I'm always available to answer. If you're using one of our competitors, I'm always available to do a comparison to see if there's options that we can bring you that they are unable to, and also if we can provide you with a cost savings at these difficult times. So once again, thanks for having me. I look forward to listening to the presentation. I'm going to mute and listen like the rest of you.
Thanks so much, Tony. We appreciate your partnership, which goes back many years. We really appreciate the support of Handcraft. They are here to tailor proposals directly to your practice, what your needs are. And we are really pleased to partner with them for our Medical Society members. I've gotten a message from Medex Waste that they're going to be a little late joining, and so we'll recognize them at the end. Just a couple of reminders before we get started. MCMS and MedChi membership is a treat, not a trick. Almost immediately, physician and practice administrator members can start benefiting from the membership value. I want to remind you as practice administrators to look for that renewal application for your physicians and make sure that you get that in as soon as possible. And then also just to remind you that we bring value to your practice and to the profession and to your patients through presentations like this, and also through networking events that are numerous. If you have physicians in your practice who are not members of the medical society, and we would love to be able to speak with you about that. Especially when you've got early career physicians who are trying to build a practice, those are things that we really focus on in the medical society. So if you have physicians that you would like to discuss about membership, I would encourage you to reach out to Emily Adams. Her email is on the screen, and she can help you to facilitate the membership of that physician. So just those reminders. Then we also have some events that are coming up that I wanted to make sure that you're aware of, that you can share with your physicians. So on Tuesday, November 8th, we have a Women in Medicine event. On Tuesday, December 2nd, we have a practice administrative event in our offices. We're going to be talking just for a few minutes about year-end considerations. What should that checklist look like as you close the year? It may not be your fiscal year, but certainly many things revolve around the calendar. And also then we'll have a little holiday reception after that particular event. We have our annual legislative breakfast with Montgomery County legislators coming up on Thursday, December the 4th. We also have a Med Talks presentation. That is our medical society's version of TED Talks, where physicians get a chance to talk about something, a new procedure, a new treatment that they provide for 5 minutes, 5 slides. And it's a very rapid fire sort of educational program. That's a lot of fun for them to do. So that's going to be at the late January, early February. Then we go to Annapolis for our lobby day on March the 4th. And that's where we meet with Montgomery County legislators. You know, the old saying that all politics is local is true. It's all about relationships with legislators and helping them to understand physicians and practice administrators' perspective on issues that they're dealing with in legislation that has been proposed. So we will encourage practice administrators to also join us for that lobby day. All of these events can be found on our website, montgomerymedicine.org/events/. So you can look at that, and then it will link you to Eventbrite, which is our platform for capturing RSVPs, and you'll see the various ticket options there. So I, again, thank you very much for joining us today. We're pleased to have you. We are pleased to be the resource for this OSHA update that we have done. And Christina is a return speaker for us, and so we're very pleased to have her again today. So I do see that Jack has joined us with MedX Waste. Jack, are you with us now? I saw him coming in. Okay, so we will recognize him at the end of the presentation and give him a chance to talk to you a little bit about what his company does, and especially the compliance activities that they do to help practices remain in compliance with this and many other regulations. So I'm going to stop here and ask our speaker, Christina Campbell-Harris, to begin her presentation. Remember to continue to mute your microphones. This is being recorded, and it will be available later as well. So Christina, why don't you go ahead and share your presentation, please? There we go.
Great. Okay.
All
Good
right. Thank
afternoon.
you.
Thank you for having me. I am going to touch on a number of different topics pretty quickly, so I won't get into too much detail on any one thing, but I wanted to give you kind of an overview of what we do here at Maryland OSHA, what we look at when we come out to do an inspection in a medical practice or medical setting. and some of the things that we look for and we ask about, and kind of what to expect should you find yourself in that situation, with a MOSH inspection. Okay. So I just want to talk about some standards that are applicable. I don't want to put you to sleep too quickly. So we'll just briefly go through those. Talk about the requirements for complying with bloodborne pathogens and hazard communication. Those are the two big standards that pretty much affect most medical type practices, and then what to expect during an inspection. So when we are talking about MOSH and OSHA standards, MOSH, Maryland Occupational Safety and Health, is the state plan for OSHA in the state of Maryland. And so federal OSHA and state plans share jurisdiction depending on, who covers whom. And in Maryland, that means that most of the private sector employers are covered by Maryland Occupational Safety and Health. And our job is to make sure that we are as partners with OSHA, that we are just as effective as federal OSHA. And so that allows us to adopt and develop our own regulations as we, if we need to, or as we see fit. In most cases in Maryland, the federal standards, the 29 CFR 1910 standards for OSHA, are also what is being enforced in Maryland. We have adopted those. So in medical settings, that means that the bloodborne pathogens, the OSHA bloodborne pathogen standard, the 29 CFR 1910-1030, hazard communication, PPE, access to records, and then some of the other standards that might be applicable depending on the type of work and the type of activities that you have going on in your practice. OSHA has a standard for formaldehyde, ethylene oxide, obviously sanitation and first aid, and things like exit routes, fire protection, electrical standards. All those might be covered at some, in your practice. But what I'm going to focus on today are the bloodborne pathogens and the hazard communication, because those are pretty universal to most practices. So we know with bloodborne pathogens that we have potential exposure, right? When we are working with human patients, potential exposure to pathogenic microorganisms and that are present in blood and other potentially infectious material, and we call those bloodborne pathogens. So obviously blood is one of those conveying routes, of materials, but we have also these other bodily fluids that potentially could transmit a bloodborne pathogen. From an OSHA standpoint, OSHA does have some body fluids or body materials that they do not consider to be able to transmit bloodborne pathogens. So when you think of like HIV or hepatitis B, we know that these can be transmitted in blood and, during dental procedures, for example, or, in some other specific body fluids, but typically not in sputum, sweat, tears, urine, emesis or vomit, feces. These are not typically materials unless they are visibly contaminated with blood. So I just want to make that distinction. There's a lot of times confusion, especially in medical practice, particularly when we get to the regulated waste part, about what is regulated, what is medical waste versus what is other. And so when we are talking about, like, from a bloodborne pathogen or a biohazard standpoint, there are some situations and circumstances where something could be disposed of not in the biohazard waste because we would not consider it to be able to transmit a bloodborne pathogen. So medical practices, of course, are generally covered by the standard. When we are thinking about exposure and how an employee could be exposed to a bloodborne pathogen, needle sticks are the most common and the one we think of often, but we also are concerned or have discussions about things like cuts from contaminated sharps. So if we have reusable sharps like scalpels, blades, scissors, things like that. Those can be considered a source of contamination. And then any contact, of course, with like mucous membranes, such as a splash, or if we were to have blood come in contact with a cut on someone's skin, that would be considered an exposure. So regarding the bloodborne pathogen standard, and really this is true for any OSHA standard, there's a certain number of things that an employer is required to do when they have employees that are exposed to bloodborne pathogens. So the written exposure control plan, things like implementing engineering and work practice controls, having PPE available and making it available and requiring it to be used, having some kind of housekeeping plan, providing or offering the hepatitis B vaccination, providing and offering post-exposure evaluation and follow-up if there were to be a needle stick, what is the protocol, providing training, and then of course maintaining those records. So those are all things that the employer should be doing when they have employees who have potential exposure to bloodborne pathogens. When we talk about engineering and work practice controls, so when we're talking about generally the hierarchy of controls, obviously what we would love to have is, elimination and substitution of a hazard. When we're dealing with bloodborne pathogens, that's really not an option. We're dealing with patients and patient care. And so, we're going to have, direct contact with some of these materials. So engineering controls is kind of where we start with the bloodborne pathogens. So when we're thinking about engineering controls for bloodborne pathogens, we're thinking about things like sharps containers. We're thinking about things like safer sharps devices. So having those needle guards or having those retractable needles, having needleless systems if we're doing, IV catheters, for example. Once we insert the IV catheter, now we don't have a needle anymore. So that's a way of providing an engineering control and engineering out that hazard. So sharps injuries, well, we hope they are not common. They are more common than we think they are. And most of the sharps injuries occur either during use or after it's been used, but before we dispose of it. So when we're looking at ways that we can try to mitigate some of those concerns or issues with a needle, a contaminated needle, we want to think about, that 75% of the time, the needle stick is going to come from either while we're using it or while we're in the process of disposing of it. So I put this up here to kind of give you an idea of the different categories of safer sharps. But when we have sharps that we're using in a medical setting, we have to consider any new device or any new technology that's out there. And we have to consider that in a way that we would expect to implement those new devices and new technologies. And so that becomes important when you are trying to categorize and evaluate new devices that are out there. We want to know, okay, what kind is it? How is it working? Passive, active, how much manipulation is it going to require? So most of the devices that you think of when you think of safer sharps are what we call active devices, meaning you have to activate that device in order for it to work and to provide a safety component to it. So whether that's a hinge guard on a needle, a retraction on, retractable sharp, maybe on a scalpel, we have a blade cover. Those are types of active devices. Not too many years ago, I guess it's a little bit old at this point. There was a survey that was conducted to kind of figure out where are some of these injuries, sharps injuries occurring. And so we know that in a lot of settings, we're still not using safer sharps devices. And I'll just give you a little bit of history. So the bloodborne pathogen standard came about in 1991. Between 91 and 2001, we also had the Needle Stick Safety Prevention Act.
Perfect.
Yes.
So we have these requirements now to not only have safer sharps devices on site, but to continually, annually look at what's out there, update our technology as needed, and make sure that these are available and feasible and that they're being used in practice. What we find is, and what this study kind of confirmed for us, is that there's a lot of medical practices in all different kinds of settings that are not using these devices at all, despite there having been a requirement around since 2001. So we're now 20, almost 25 years later, and we still have a lot of violations for not having a safety device on a needle at all. So I wanted to bring that to your attention because I know we're seeing it out there, and it may apply to you. And if so, reach out to me and we can help. All right. When you're thinking about, doing your annual review of your your safety devices and your safer sharps, some things to think about are not only, is this feasible? Can we use it in this practice? But you also want to think about things like, is it going to work for all of the people that you have working for you? Does it work with right and left-handed people? Is the safety feature, does it operate reliably every time you activate it? Is this something that is going to require a lot of education and training, or is it something that might be more easily implemented? Is the safety device or safety feature easy to bypass? Because if it's easy to bypass, people don't use it. And so those are the types of things you want to think about when you are bringing in new technology or evaluating that for potential use. So this is something that, that annual evaluation or annual consideration should be happening in your practice. It's something that the standard does require, and that we want to encourage the use of the newer technologies that are coming about in order to eliminate and reduce that risk of sharps exposure. The annual review and evaluation should also include solicitation or, bring in people who are not managers, right? You want your boots on the ground, your folks that are actually using these devices, to bring them in to, really experiment and look at the devices and get their input on how well it would work in your practice. And there are a couple good tools out there. One for showing you kind of what different types of devices are out there, both brands and styles and different types. And then also being able to do that evaluation thoroughly and having an evaluation, almost like a checklist or a set of questions to kind of walk you through as you're looking at new devices. So sharps containers are another thing that we see some issues with, particularly in medical practice settings. So we know that sharps containers, that we're using them to collect our sharps devices, so our needles, our scalpels, things like that. What we often see and what we should not see is sharps containers being used for things that are not sharps, right? Like people throw gloves in there, they're throwing tubing in there. And what that does is creates a lot of bulk in the sharps container. And now we have a potential for a needle not going down to the bottom of the sharps container, but sitting on top maybe of a glove that got stuck at the top. And so we see sharps containers that are being used for things that are not sharps. And we see them overfilled frequently, right? So, whether we didn't have another one to put out, or, the company hasn't come, the waste disposal company has not come to pick them up recently. Overfilling is a big problem. And then one of the other things that we see more often than we should is like opening of the container. For whatever reason, this does happen, but it should not happen, right? Those sharps containers need to be closable. They need to stay closed. They need to never be opened once you start putting sharps in there. and they need to be replaced, frequently enough so that when someone is putting a sharp into a sharp container, they're not at risk of being stuck with either the needle they're trying to dispose of, or maybe another needle that has been disposed of, improperly or inadequately, and now they are stuck with a needle from that, that transaction of trying to put a contaminated sharp into the sharps box. So those are some things to think about. All sharps boxes, if they are if they meet all the criteria, they're usually the FDA has like approved them for use. But generally they need to be leak proof, puncture resistant. They need to be labeled, or they need to have be read and have that biohazard label on them. And they need to be easily accessible. So not just in the room, but also in the room near where the device, the sharp is going to be used, and then also hopefully disposed of. So we want to limit the actual physical distance between where the contaminated sharp is being handled and then where it's being disposed of. So again, those best practices are to replace it when it's 3/4 full, so that we don't have a risk of overfilling. Put only sharps in the sharps container. And then there are some recommendations from NIOSH or the CDC about where to place those based on whether your providers are working at a seated level or a standing level. And obviously, if you are like a pediatric practice, you're not going to want that. You're going to want it maybe a little higher up, so that your little people hands can't get to it. So there are some considerations for different settings, and then obviously different work practices. We talked about that. One thing we see a lot is the sharps container under the sink, or under the behind a cabinet door. And this is something that it's fine for normal biohazard waste if you want to put that under, but a sharps container should really be out close, able to be accessed, so that we are not fumbling and trying to open a door to get to the sharps container. Reusable sharps are another area where we find problems. So a lot of times before the sharp goes to the autoclave to be cleaned, it has to be cleaned, right? So there's an agitation process or a cleaning process of some sort. And in those situations, sometimes we need a tool or a grabber in order to be able to manipulate or handle those reusable sharps, so that we're not just sticking our hands in and potentially getting a cut, or having some other kind of exposure to that sharp that hasn't been fully sterilized. Okay, so after we've exhausted all of our engineering controls, we have what we call work practice controls. So these are things that we do to alter our work in order to reduce the exposure to the bloodborne pathogen. So things like our universal or standard precautions, hand washing and hygiene, not having food in your laboratory area, or, in your, not having, not putting on makeup, where you would, have exposure to blood or body fluids. Things like making sure containers are labeled, handling waste and contaminated laundry in a specific way so as to avoid exposure. And then obviously that proper cleaning and disinfection for when you do have a spill, or we're, doing a cleanup of some kind of blood or other potentially infectious material. So OSHA says that at a minimum, you have to use universal precautions when working with patients, just because we know that there are certain body fluids and human blood that we should treat or as if they are infectious, whether we know them to be or not. Standard precautions, which is very much implemented in most hospital settings, is we treat all patients, all body fluids, anything that comes out of the patient, we treat that as potentially infectious. And that's more of a CDC recommendation, JCO requirement, that kind of thing. OSHA is, OSHA will accept either. So again, those work practice controls, making sure we're hand washing before, we're leaving an exam area. No mouth pipetting. I know that seems like crazy, but that wasn't that long ago that we used to do that. Not recapping needles, not eating, smoking, applying cosmetics, anywhere where you could have potential exposure to bloodborne pathogens. Labeling containers. So most containers come, if you buy them commercially, they come already labeled. Things like your red biohazard bags, your sharps containers, stuff like that. If it's not, for whatever reason, it needs to have some kind of symbol, or you need to have just an understanding in your practice that all red bag or red box, it potentially contains medical waste, regulated medical waste. So when we talk about regulated medical waste, and this is for smaller practice settings, this can become a little bit, I don't want to say contentious, but we get a lot of phone calls about, oh, everything has to go in the biohazard waste, and that's really expensive. And, because it is, an extra cost to have to handle that regulated medical waste and have somebody come and pick it up. So here's what I will tell you and what OSHA says. For something to have to go into the biohazard waste, it has to be, it's either a contaminated sharp, that definitely goes in biohazard waste. It has to be liquid and dripping and saturated. So it has to be able to be released from whatever the medium is, whether that's in its liquid form or its dried form. So if we have a Band-Aid, for example, with, 0.5 cc's of blood on it, that can go in the regular trash. The Band-Aid is designed to absorb that. That shouldn't be a problem. If we had a cotton ball that was soaked in 10 mils of blood, that's probably a regulated waste. So there can be some distinction between what can go in regular trash and what can go in the regulated medical waste for the purposes of OSHA. There are some providers or some practices that prefer everything. If it touched a patient at all, it goes in the red bag waste. That's obviously fine. That's going above and beyond what OSHA would require. But if there's a concern about weight and volume and bulk of regulated waste and managing that, there are some things that probably most things could go in the regular waste stream. And we talked about sharps and sharps containers. So one of the requirements for bloodborne pathogens is to establish and maintain an exposure control plan. And really that's just an outline or a summary of how you are doing all of these things that we're talking about, right? Like how you are managing your engineering controls, your work practice controls, how you're doing your disinfection, how you are providing your training and your hepatitis B vaccine. So it's really just a plan of how you are doing that in practice, putting that in writing. But the plan does need to include a procedure for how you're doing your cleaning, whether it's daily, weekly, monthly, or all of the above. And then what types of disinfectants or cleaning products that you're using, especially in areas where we might have exposure to bloodborne pathogens. We want to make sure that the disinfectants themselves meet certain criteria and thresholds. So the EPA puts out a list of what we call registered disinfectants. OSHA says that your disinfectants for bloodborne pathogens have to be on list S at a minimum. They can also be on list A or list B. They can be a high-level sterilant or disinfectant that's been cleared by the FDA. You can also use bleach. Fresh bleach solutions are acceptable. But if it at a minimum, it has to meet the criteria for being on list S, which is effective against HIV, hepatitis B, and hepatitis C. So that's kind of like your threshold for a disinfectant. If you're using bleach solutions, they should be made up every day, or they need to be in those special spray bottles that have water on one side, bleach on the other. Because once you mix the water and the bleach together, it becomes less effective over time. So we want to make sure that it's still, you know, able to have those disinfectant properties. So we want to make that up fresh every day if that's what you're using. I thought this was interesting, just to kind of give you an idea of how much of, like, let's see if we're talking about blood, how much blood and how many viral particles would be in that amount of blood, you know, were it to be on a surface, you know, whether it's a table or a floor or a counter or a fabric, anything like that. So hepatitis B tends to have the highest number of viral particles. It also, as you would expect, also is one of those transmissible infections that is more easily transmitted than either hepatitis C or HIV. So you can kind of get a sense for how many viral particles, you know, and how much is needed to, and potentially initiates an inspection. Listen to me, an infection. So PPE is one of those things you're going to have on site. At a minimum, you're going to have gloves. You may also need gowns, face masks, goggles, glasses, face shields. Those are going to be your personal protective equipment and you're going to think about, what is the potential for a splash? What is the potential for direct contact? What is the potential for exposure? And that job hazard analysis or that risk assessment is going to drive what kind of PPE you ultimately provide and require in your practice. One of the things that we want to just kind of emphasize is that for one thing, PPE is something that needs to be provided by the employer. It has to be provided by the employer at no cost. There has to be multiple sizes. There has to be able to fit all the people that are going to be wearing it. It's the employer's responsibility to make sure that it is being worn where it is needed. And then we also want to make sure that we're not cross-contaminating, right? So when we have, you know, gloves, for example, we want to take those off and, you know, wash hands, sanitize before we leave the room, not after. We don't want to be touching like the door handles, obviously, with our, you know, contaminated gloves. One of the questions we get often is about whether or not there has to be a sink in every exam room. And the short answer is it depends. The long answer is it depends on what kinds of tasks, what kinds of activities, what kind of patient care functions are being performed in that room. So as an example, if you have, you designate one exam room for just your sports medical physicals, right? And we're not doing any kind of blood draw. We're not doing any vaccinations. We don't have any needles. We're not really doing anything that would generate an exposure. We don't need to have a sink in that exam room. On the flip side, if we are doing, pelvic exams in, an OBGYN office, there needs to be a sink in every room that's being done. Just because of the nature of the handling and the body fluids that we are going to have exposure to. So it really depends. I'm happy to have more conversation about that, but I'll put that out there as a question that we get often. Employers have an obligation to offer the hepatitis B vaccine to their employees with exposure. What that means is you have to offer it. An employee doesn't have to take it, but if they don't accept it, like let's say they're, most people, especially if they're, 40 or younger, have had the hepatitis B vaccine either as part of their professional career, or they've had it as a childhood vaccination series, right? So most people have had the hepatitis B vaccine. if you offer the hepatitis B vaccine to your employees, or when you offer it to them, what you want to do is make sure that you either get a copy of their vaccination record so that you have their, their vaccine status, and you also get them to complete the declination form. So there's a mandatory declination form if someone declines the vaccine, that they should be, completing and signing, and they understand the declination form basically says that, this is being offered and provided. At any time, if they change their mind, they can come back and receive the vaccine series. One question we get a lot is if an employer has to offer, or could offer, I guess, a titer instead of the vaccine, because the titer tends to be cheaper in cost than doing the whole vaccine series, the three in series. And the short answer is you can offer it as an option, but you can't make it a contingency. So you can't say, well, I'm going to do the titer first, and if you don't have immunity, then I'll give you the vaccine. It has to be the employee's choice, but you certainly can offer that as a choice. And obviously, this is something that you can do in-house, and a lot of people do in-house. You can also, have a third party or an occupational health provider that's unaffiliated with your practice also provide that for you. So post-exposure, or let's say we've had a needle stick, what to do after that happens. I cannot tell you the number of calls I get in a week or a month with somebody from a physician practice calling and saying, we had a needle stick, what do we do now? And so while I'm walking them through it, I'm also reminding them this is something that you should have had already kind of thought about and had a procedure for before it happened, because there's certain things that have to be done after someone has an exposure incident, whether it's a needle stick from a contaminated needle, or a splash in the eye, or any other type of exposure. So, and there's time frames in which that has to happen. So, within 4 hours, the post-exposure evaluation and treatment should be well underway. And a lot of times what happens is if you don't have it in place beforehand, 4 hours goes pretty quick. And now now we're in a position where either maybe we're after hours, maybe we, can't get a hold if there's, we need prophylactic medication, we can't get a hold of it because there's not a pharmacy that's open. There's a whole number of factors that can, really complicate things. And the idea is if we have an exposure incident, we want employees to be able to get evaluated and treated if needed immediately. That's the idea behind it. So when we talk about exposure, or post-exposure, what I recommend that that practices have, one is you got to think about who's going to be your provider in that situation. So if you are normally providing or offering hepatitis B vaccine to new employees that come in, and you also want to be the treating provider if there's an exposure incident, you have to think about the relationship between you as the employer and you as the provider. And if you have, most of the time what we recommend is that you have an alternative option for people, right? So if you have an employee who has an exposure and they don't want their employer to also be their treating provider, that there is another option available for them. And because part of the post-exposure treatment and evaluation is offering, one, having knowledge of the public health service guidelines for occupational exposure, and two, offering that risk counseling, offering the potentially prophylactic medication, based on what the guidelines are recommending. And so you want your provider to be knowledgeable in those areas and really understand, what the implications are so that they can accurately, guide and treat that person as a patient, not as an employee, if that makes sense. There's also certain things that the provider needs to know, like about their hepatitis B vaccination status, about, how the exposure incident occurred, what kind of, are we talking about a large bore needle, a small, 31 gauge needle? Are we talking about something that doesn't even have a bore? It's just, a lancet, for example. All of those factors come into play from a treatment standpoint, about guiding or recommending to an employee about what kind of follow-up, prophylaxis and or testing that needs to be done. One of the other requirements for bloodborne pathogens, and this is true for all of OSHA's standards, is training, right? We want to train our employees, make sure that they know about all of the things that we've talked about, what's in your exposure control plan. And all that needs to happen before you, like, as soon as they're onboarded, pretty much. It's not something that really should wait. They should be offered the hepatitis B vaccine within 10 days of employment, and the training needs to happen first. So all that kind of needs to be as part of the onboarding process. There are certain things that are required in the training, and this is just a snapshot of it. So there's actually, like, I don't know, 15 different elements that have to be talked about or have to be presented as far as the training information is concerned for bloodborne pathogens. I'm happy to get into more of that, but if you've taken any bloodborne pathogen training in your career, you kind of have a handle on, what needs to be covered. And again, that written plan is something that we're going to ask for during an inspection, and it should be an outline, a summary, a document that tells me how you're offering your Hep B vaccines, how you're onboarding your employees, how, who is exposed and how they're exposed. Your exposure control plan has to be reviewed and updated at least every year. And again, you want to make sure you're including that SHARPS technology, the newer technologies, having some input and solicitation from employees. That needs to be included as part of that review. So some of the most common violations we see in medical settings or medical practices, not having or not using safer sharps, and we see both. We see you can absolutely go out on the market and buy needles that don't have guards on them. In fact, they're cheaper, and I think that's why a lot of practices end up using them. They're fine for veterinary, and they're fine for certain activities where we're not contacting a patient. Maybe we are transferring a vaccine from one vial to another or something like that. Like, that's fine. You don't need a guard on that kind of needle. But as soon as it goes into a patient, it needs a guard on it. So, and you want it to be on there before you actually use it on the patient. Not having an exposure control plan, or we'll talk about hazard communication in a minute, but not having a written plan or not having a plan that meets all the requirements. Not offering the hepatitis B vaccine. So what we see is we'll go into a practice and employees will say, like, oh, I've had the vaccine before. Okay, but did, at this practice that you work at now, where you offered the hepatitis B vaccine, and if the employer has not offered it, they've not obtained any vaccination records, they don't have a declination form, it wasn't offered, right? So we got to have that documentation there. Providing the training, and I have another slide that's similar, but has a lot of the hazard communication. So that's kind of like a super quick down and dirty of the bloodborne pathogens. One of the other standards that we look at and that we are, looking for documentation of is hazard communication. So these are chemicals that you use in the practice, and it's everything from your cavicides, your sandy wipes, your, any kind of chemical that you use, whether it's for cleaning, for disinfection, things like reagents for point of care tests are generally not covered. Things like printer cartridges are not covered. Those aren't considered chemicals. but almost every practice I go into has at least 1 or 2 or 10 chemicals that they're using on a regular enough basis that they need to implement the requirements of the hazard communication standard. So we have 5 elements when we're talking about chemicals. The things that we need to have are that written program again, and again, it's just a summary or an outline of how you're managing all these things in real life. Having that program, creating a chemical inventory list, making sure that for each chemical on your list, you have a safety data sheet for that chemical. So every chemical has a safety data sheet that the manufacturers are required to generate and implement and push downstream to you. Making sure that all containers are labeled and making sure that we provide training to employees. So if you haven't noticed, there's a theme to a lot of these OSHA regulations. It's, we need a program, we need training, we need to make sure we're, giving employees the information and the education they need so that they understand the hazards of what they're working with. So chemical manufacturers, have a product, whatever that chemical product is, they put a label on their original container, they provide a safety data sheet, but it's up to the employer to make sure that that's still the case when it comes downstream to them, right? So if you get a container in, it should have the manufacturer's label on it. It should come with the data sheet. If it doesn't come with the safety data sheet, then you have to reach out to the supplier or the distributor and obtain that data sheet and then maintain it, right? Whether it's in an electronic database or a paper binder, any of those things are fine. But the idea is we want to have the information there and available so that an employee who's using that product can go right to the label or right to the safety data sheet and know what the hazards are and, know what PPE potentially to wear, and know what to do in an emergency. So these are things that we want to make sure we have that we have available and that are accessible to employees at all times. If you have been working in the field for more than 15 years, the chemical training or the chemical information, the hazard communication has changed a little bit. So about 13 years ago, I'd say, the United Nations adopted what they call a globally harmonized system, which basically was an agreement between or within the UN that all of these countries could agree on a standardized way of labeling, of classifying chemicals, of information on safety data sheets. So all of that in the last 13 years has been updated in terms of the manufacturer's labels have been updated, the safety data sheets that come with them have been updated, and potentially reclassification of chemicals. So if you're still if any of your data sheets say material safety data sheet on them, they're old, you need to update them. We are also using for labeling, manufacturers are using these pictograms as a way to label a chemical and identify what the hazards are. So part of the training that you give to employees is going to include not only what's on a label, how to read a label, but what those pictograms mean, and then the information that's on a data sheet, how to access it, that kind of thing. So as for your hazard communication step by step, the employer, what I tell most employers is first get a list of all the chemicals that you have in your workplace, put it in an inventory list, make sure all of those containers, all those chemicals that you have labels on them, whether it's an original container or you've created a secondary container like a spray bottle, that also still needs to be labeled, at least with the name and the hazards of the product. Obtain the safety data sheets for all the chemicals, put them all together, put them in a book, put them on, your internal intranet server, whatever you want to do. As long as employees have access to them pretty much all the time, that's acceptable way to maintain them. Providing training to your employees about the chemicals they use, about any hazards associated, any PPE they would need to wear, and then developing that written program. Commonly, we see violations of the standard where we don't have any safety data sheets. We're still working on material safety data sheets from like 15 years ago. We haven't updated those. Not having a written program. The training is either not there at all, or it's not very, it doesn't meet all the requirements. Containers aren't labeled, that's a big one. And then not having a chemical inventory list. Whew, we are getting to the end, I promise. So when a MOSH inspection happens, particularly in a medical practice setting, we are never going to come in and do a wall-to-wall, what we call a programmed inspection. You're never going to be on our list. The reason we're there is because there's been a complaint. We got a referral from either, we've gotten them from physicians before, who have treated employees as patients. We've gotten them from like maybe a fire marshal, they've gone in to check something and they, identify what they think is a problem. We might get something from the health department, or there's been an accident, right? So something happened that alerted, and we were alerted that there was, an incident, an employee injury, and somehow that's how, one of those things is the reason why we're in there. It's never because you just were on a list somewhere and we went down and randomly selected. So we don't go into medical practices as a general rule unless we've received one of those complaints, referrals, accident, unless we have a reason to. And so that's usually the way that an inspection is being initiated. We do show up unannounced. I am very sorry to tell you, that's just the way the law is written. We show up unannounced, and so you don't get any prior notice. As far as the inspection process, generally the first time we are there, which may be the only time we are there, takes anywhere from like 2 to 4 hours, depends on a number of factors. But there's a lot of information that we have to obtain in that time. The first thing we do is have an opening conference. We meet with a member of management. We explain why we're there, what we need to do. Then we have what we call a walk-around inspection. So we're obviously looking at the complaint items, but we also look at other things while we're there. We take videos, we take photos, we take measurements. We might do some sampling, for example. So, all of those are things we might do during an inspection. We might do that during the first visit. We might do that on a subsequent visit. Any subsequent visits we will schedule with you. We don't show up unannounced for subsequent visits, but the first time we do show up without anyone knowing, except for us. I mean, we know, but you don't know that we're coming. We do a records review. So we ask for programs. We're going to want to see your HAZCOM program, your bloodborne pathogen exposure control plan, your Hep B vaccination records, any injuries or illnesses that you may have had. We're going to ask for safety data sheets for chemicals. We're going to, open drawers and open cabinets and ask you about a lot of the things that you have that you're using. And at some point we will have a closing conference. Sometimes it's the same day, but most of the time it's later. A lot of times because we have programs that we're reviewing, we need, a minute to look at those and really digest them, and then, make recommendations based on that. So a lot of times the closing is several days or several weeks after the initial inspection is initiated. And then any violations of any of our standards are subject to citation and penalty in accordance with the law. And just so we are all clear, because I think the health department may be a little different in terms of how they operate when they come in to do an inspection. Once we identify that there's a hazard and we have, we are not in compliance and there's things that we need to do to correct those violations, we have to issue a citation at that point. We don't have the option of saying, well, why don't you get it fixed and we'll come back in 30 days and, and then everything will be good as long as it's fixed. Unfortunately, at that point, it's a citation. So that doesn't necessarily mean a citation comes with a penalty. A lot of them don't, but a lot of them do. And, so any violation of any standard during an inspection is subject to potential citation and or penalty. While an inspector is there, they will be conducting interviews. They conduct interviews with management, they conduct interviews with employees. They do those separately, and they're really asking everybody the same types of questions. What kind of chemicals do you work with? What kind of PPE do you use? What kind of training is offered? And it's really to get a picture or an idea of what's going on in practice, right? In real life. The inspector should be communicating with management throughout the process. They should be asking notes. They'll be asking questions. They'll be taking notes, photos, videos. They can't give you a copy of any of those things, but you are more than welcome to take either side-by-side photos or the same notes, or nothing is a secret. I mean, it should be very transparent. And if it's not, then you can certainly ask it to be more transparent, or to have the opportunity to take the same pictures and, whatever else you would like to do. One of the other things that inspectors will be doing is pointing out potential hazards or potential violations and offering suggestions for abatement or correction. There are, what do they, I'm going to use a phrase that I don't know, I probably should not, but more than one way to skin a cat, I think they say. So there's a lot of times more than one way to abate something. Just because the inspector says, hey, you need to XYZ, if you have an alternative way of maybe correcting something, that's something to bring up at that time with the inspector, so that you can have a conversation about it. And then at some point, again, during the closing, the inspector will review again any issues, concerns, problems, any questions they have, any violations, and whether or not they are recommending citations to the assistant commissioner to be issued. And all of our cases go through several layers of review. So the inspectors are never the ones that are issuing the citations themselves. They're recommending citations. They're doing the documentation and they're getting the information. But at the end of the day, it's somebody higher than them that says, yes, I agree. I think we have a citation here. So it goes through several levels of review before it ever comes to you as a citation. If it comes to that. MOSH has, so I'm on the enforcement end, if you can't tell, but MOSH does have a consultation service. It's free for most employers in Maryland, most small employers in Maryland. And they can do anything, they can do full wall-to-wall, they can do safety, they can do health, it's really whatever you want them to do. It is in the same. They do things similarly to how we do in enforcement in terms of asking questions, asking for programs, things like that. But there's no citations or penalties. So all you're getting them to do is to come in, identify the problems so that you can fix them, so that you could, hopefully be in compliance if you did have a MOSH inspection. And that's it. It was a lot. I cannot see the chat, so I don't know if there are.
Yeah, thank you again for such a great presentation. And you actually were so comprehensive that you answered a couple of the questions that I had actually put in there. And one of those had to do with, do all employees have to be trained on OSHA and MOSH, or just those that have potential exposure? So thank you for addressing that. You also just went through how an inspection is activated, and that's by complaint. So we get these questions a lot at the Medical Society, and so really appreciate you addressing those. We do have 2 additional questions, and then we want to ask Jack to just mention what MedX Waste does. So one of the questions is, would this particular presentation count as annual staff OSHA training? And if it doesn't, do you, the state, offer something for free use by medical practices for OSHA training?
The short answer to that is no. We didn't get into, like, I would say 75% of probably the depth that needs to go, that you should probably go into. There are some resources for training, and I can, once we're done here, I can pass those along. But at the end of the day, you're gonna want to need to make sure that your training is specific to your location, your site, right? Your employees need to know where your safety data sheets are kept. They need to know what your procedures are for if there's an exposure incident. So a lot of that training, even if it's generic in, transmission of disease and, some of the other things, it still has to have some site-specific components. So it's going to need some input from you as the employer.
Sure. Thank you for that. But this program, it doesn't hurt. It doesn't hurt to document that you attended this, and because it certainly could help if OSHA came knocking. So we also have another question. Private practices, regardless of specialty, are required to offer Hep B, correct?
That's correct.
That's correct. Okay. And then there's another question. Is there one resource or checklist of all the OSHA requirements for a new primary care clinic? Where would you suggest they might go?
There are, and I would tell you to go to OSHA.gov, but right now the federal websites are a little wonky, and it's even I can't find stuff going directly to OSHA.gov. Like I have to Google what I'm looking for and then go find it through a search engine.
Right.
So what I can do is send you some resources or specific links that I think would be helpful to start with. But yes, I do believe they have a publication or a pamphlet for medical practice
Right.
settings.
So if you'll send those to me, I think that would really be helpful. We have a lot of physicians who are starting practice in Montgomery County and are looking for the same information. So we'd be happy to keep that as a resource. And I know that Jack, who works with MedX Waste, is a particularly helpful resource in all of these areas. And so, Jack, we want to give you a chance to introduce your company and just share how you help practices comply.
Yeah, thank you for the introduction, Susan. So my name's Jack. I'm the owner of MedX Waste Maryland. We're local here right out of Brockville. And we haul and pick up waste, medical waste from practices across DC, Maryland, Virginia. But we don't only haul, we also offer the online OSHA compliance software that I wanted to highlight today. As you can see from what Christina's was, it's pretty extensive and what you guys got to take control of within your practice, and you have busy days. So we try to make it affordable for you, easy to use, and keep things stress-free for your medical practice. So it's all directly online through your customer portal. A couple practices actually in here utilize it. But it covers every OSHA and MOSH trainings that may be required by your practice. So that includes the bloodborne pathogen training, that includes HAZCOM, PPE, fire and safety, and then even DOT training for those in your practice that actually handle the medical waste, package it, and handle those sharps containers. So the system generates the certificate for you right there, stores it for you, even sends you reminders for trainings that may need to be updated annually, and it keeps it all securely stored right there in your portal. And aside from the trainings, you can also access stuff like that you highlighted in here, the safety data sheet library. You can use it for OSHA log 300 record keeping, store your exposure plans in there. So if you were to have one of these inspections that you guys were talking about, it's all right there for you. You would pull it up right there. So for anyone interested, if you want to schedule a call, I can show you what the actual training portal looks like and how it could potentially simplify your current process. And I love what I do as a hauler, and I'm constantly learning and staying on top of changes and regulations happening within the medical industry, especially with help of organizations like Christina from MOSH here and the Maryland Department of Environment. Basically, the end goal here is to be a valuable resource for you all to keep your practices compliant. So I thank you, and I hope to talk to some of you soon.
That's great. So Jack, would you please put your email and
Yeah.
your contact information in chat? That would really be helpful. MedX Waste is a partner with the Medical Society, and we're very proud of this partnership and the way that we help practices to stay compliant. So last chance, any other questions? If you want to unmute yourself and just ask a question, that would be fine too.
Rosie, I just had a quick question.
Yes.
Thank you so much for arranging this, Susan. This is very helpful. And Christina and Jack, thank you so very much for, for your presentations. Susan, I guess the question is to Christina and Jack. The way we do have our protocols, but I wanted to have some generic examples, like just to make sure we have everything we need in one piece of paper for bloodborne pathogens, for hepatitis. Is there any resource that we can look at? That's one question. The other thing, I must have missed it, whether or not we need to have OSHA training for front desk as well, yes or no? I didn't think so, because the way I look at it, it's people that are, handling body fluids and blood products and stuff. We don't really use chemicals, so it doesn't really apply to us. Those are my two main questions.
They're good questions. So to answer the examples, yes, there are examples, both of the programs and also of like training content and training, materials. So I can, pull those up and send those as well when I send the other stuff to Susan. And then as far as front desk or people that may not have exposure, you will make that determination based on, I guess, whatever tasks or activities you have them doing. So sometimes you have front desk people or, those type of folks who are like sending out samples, or they're handling samples that are given to them and then putting them into, the LabCorp box or whatever. If that's the case, they might be covered. But generally speaking, if they're just handling paperwork, just dealing with billing, just dealing, handling like patient concerns, and front desk type stuff, then no.
And the Hep B requirement for offering to them is the same then, yes? You don't necessarily have to offer free Hep B vaccination to front desk who are not cross-trained or who are not really dealing with the back. And
correct. Yes, they would not be covered under the bloodborne pathogen standard.
And so sorry to cut you off. The last question was, of course, we know that there's no food to be at the medical assisting station in the back office, no makeup. Two other questions I have in that was, is water even having a beverage against OSHA? Because I've been stricter about it. I wasn't sure if I didn't hear you say about water or drinks or something. I know you did mention food.
Yeah, and that does get kind of tricky. I would say it really depends on what's going on in those back settings. But out of an abundance of caution, I would say no food, no beverages, no eating, no like hand to mouth, right? You don't want anything touching where you would have just, maybe, I don't know, transferred a sample from one container to another. You don't want to then have, eating, drinking, hands touching, all the things. That's the idea. So I think it kind of depends on like how differentiated you have those different tasks. And, could they have a bottle of water outside of that area, but not right on the table? Yeah, I think that'd be okay. As long as you have a hygiene plan or, a practice of when you leave this area, you wash your hands,
So one last thing, when we were training way back decades ago, right? The medical assistants nor nurses could not have their long hair loose, nor could they have a whole nail polish, a bright color nail polish, let alone long nails. Now, I can't hire anybody with that kind of requirement these days, okay? If, I mean, I have people working in the back office or in the front office with 3 inches long nails that are like, I don't know, they spend hundreds of dollars trying to keep them that way. Like, I don't know that I can even tell them to cut them off. So I
Yeah.
don't know where we stand on that.
So OSHA doesn't have a stance on that. That comes from a standpoint of patient infection control. So from an OSHA standpoint, OSHA is concerned about the employees, the workers, and their safety. Once you get into patient safety, that's out of our purview.
I haven't had anybody complain that they were being poked, so I guess I'm just gonna keep quiet on that.
Well, and I think, it's, in most healthcare settings, and I think, a lot of the guidance comes from the CDC, but obviously the Maryland Department of Health has some oversight in Maryland for patient care. I think it comes from a standpoint of infection control, right? Where you have things like chipping nail polish. If you have long nails that, are not might have a lot more things get picked up underneath them. And then you're taking those hands and you're providing direct patient care, even with gloves on. That's where the infection control piece of it comes into. So that's where a lot of those policies come from of like, they have to be short, they can't be more than this length, and no crazy colors, or no, because you don't want to introduce something into the environment that unnecessarily.
Thank you so much.
Any other questions? Well, we want to thank Christina, our speaker, and we want to thank Jack and Tony for being with us and sharing what they do and how they support your medical practices. We thank all of you for your support and engagement with Montgomery County Medical Society. As I said, we will be sending out this recording and the presentation to you if you are a practice administrative member. And then we will send out a link to our YouTube channel in our e-news on Sunday so that anyone else can access it. So thank you again, Christina, for an excellent presentation. We look forward to connecting with you again next year. And we hope all of you have a great evening and happy Halloween. Thank you.